Hello, everyone. I'm Dr. Amanda Peterson from the Department of Language, Cultures, and Literatures. I'm a Spanish professor, and I'm here with Dr. Dominguez to welcome you to our course, Pandemic Times. This is a course that was made possible by the generous support of the Provost Office and the College of Arts and Sciences, and also the Humanities Center. And there were lots of people that helped us put this together, including Dr. Ronald Kaufman and Provost Baker, who enabled first-year students to enroll in this class before they were officially starting at the university. This is a class that we thought was really important because of this moment. It's a very important moment. We talk about it being unprecedented in our lifetimes, but we felt that having an interdisciplinary discussion on this was a very important segue and introduction to the importance of liberal arts education. It enables to have us look at this problem and issue from many different points of view.
I've been delighted to be involved with the faculty. The 21 faculty members from across the university are participating in this course, and they bring so much expertise from so many different fields of study. And this is, I personally, since this whole pandemic began, have never been so grateful for my own broad and multidisciplinary education. And I've never been so glad to be a member of an academic community with so many really well-informed people who have so much to share with each other and with our students and with the public about all of the different aspects, scientific, social, medical, to this crisis. When you think about as we welcome our incoming students to USD, when you take a liberal arts education and you'll be doing an interdisciplinary education in the core curriculum at USD. It's important to think a little bit about what those disciplines are individually and what they offer collectively. And that's the nature of a liberal arts education. To become a professor, that means you study the same thing for years and years and years, and you learn everything that anybody's ever learned about it, and then you have to add your own, scholarly contribution to that community. And so people who are academic professors, they compete with each other, they collaborate with each other in developing that collective expertise. And then we continue learning throughout our careers to pass that knowledge along to our students. And so, this class is a great manifestation of that interdisciplinary and multidisciplinary community in the liberal arts at USD. And we're just delighted to be able to pass along, some little snippets of that accumulated multidisciplinary knowledge that as that knowledge applies to this very specific and very real problem that we're all facing together.
Excellent. And I think as we welcome the public to this discussion and this class through these videos that we're putting on the Humanities website, I just also kind of want to share the delight that Dr. Dominguez has had as we've been able to listen to our colleagues, and we have been in awe at their intelligence and smartness and their ability to unpackage and teach us things that we even we as professors have been learning. And I know that so far the student reaction has been also very excited and about having the opportunity to be able to hear from actual experts their opinions on what's going on about the pandemic today.
The topic for today is critical literacy. What do we need to understand about pandemics before we can evaluate its context and some of its more nuanced implications? So we're going to begin today with some professors from the more hard sciences, beginning with Dr. Arietta Fleming-Davies, a biologist. And what I'm going to introduce each of these faculty members to you, and I'm going to ask them to show up and say hi here and to say a few words about what their academic discipline is. So Dr. Fleming-Davies, would you start us off?
Yes, hi everyone. My academic discipline is actually the study of infectious disease and how it spreads in populations. So I'm really excited to be talking with you more about that today.
Great. And our next panelist will be Dr. Daniel Sheehan, who's a physics professor. Dr. Sheehan?
A physicist is a philosopher who does mathematics, or a philosopher looking for mathematics. Physicists model the world. And so over my career, I've been looking at planetary formation, plasma physics, the physics of time, the basics of thermodynamics. I'm interested in everything. And this course, I think, touches everything. So I'm thrilled to be here.
Thank you. Our next panelist will be from the social scientists, Dr. Alyson Ma, an economics professor. Dr. Ma.
I am excited to meet you folks. So economics is a study of choices people make to fulfill their wants due to our limited resources. But I should warn all of you that once you view the world through an economic lens, you will not be able to go back. So as you go out and about to your favorite places or mall, you're going to notice things and ask questions such as, why is that kiosk still open? I've passed it so many times. I've never seen customers and they're still open. Why is that? You're going to notice a lot more things as you're out and about once you sort of view the world and understand why people make the choices that they do.
Thank you. And the last section of today's critical literacy panel will feature the more social science and history. So if I can introduce Dr. Andrew Tirrell from the Political Science and International Relations Department.
Hi, everyone. Basically, I mean, I think you could ask 10 political scientists and get a slightly different answer. What is political science about? For me, it's of course, it's about governance, but what that means to me mostly is balancing order and justice. So thinking about how do you make sure society runs smoothly? How do you make sure that everyone understands the rules that keep us safe, that keep us prosperous, but balance that against justice, making sure that there's a fairness in the systems that guide our lives, making sure that we are trying to address vulnerabilities and give people the opportunity to live the best lives that they can. So that's what it means for me. Great to meet you all.
Wonderful. And last but certainly not least, we have Dr. Channon Miller from the History Department. Dr. Miller.
Hello, everyone. As shared, Dr. Channon Miller in the History Department. I specialize in U.S. history and in particular Black life, history, and culture. And as an African-American historian, I ultimately really align with the sense, as many of my peers do, that to understand Black viewpoints, Black perspectives, the Black past, and the Black present is the best way to understand U.S., one of the best ways to understand U.S. society and how to navigate U.S. society and its politics and beyond.
Wonderful. And so with that, Dr. Peterson and I will step out of the way and toss it to Dr. Sheehan, and we'll start on the content for today's class. And there will be, if you have questions, throw them in the chat and we'll come back to them at the end.
It was the best of times. It was the worst of times. It was the age of wisdom. It was the age of foolishness. It was the epoch of belief. It was the epoch of incredulity. It was a season of light. It was a season of darkness. It was the spring of hope and the winter of despair. We had everything before us. We had nothing before us. We were all going to heaven. We were all going straight the other way. The period was so far like the present period that the many noisy authorities insisted upon receiving it for good or for evil, relative sense only. Now, many of you may recognize this as the opening to Charles Dickens' A Tale of Two Cities, which was written over 160 years ago. But it could have been written yesterday or in this morning's paper. It is a season of light and a season of darkness, of belief and incredulity, all of these things. And the noisy authorities who insist on it being recognized strictly in superlatives, a unique time, an historic time, an unprecedented time. It isn't. Disease has been with human beings as long as they have assembled. There have been epidemics as long as there have been towns and cities, and pandemics as long as there are civilizations. So today, and for the next 5 weeks, we are inviting you to join us in an academic adventure, which is to explore all aspects of pandemics and plagues and epidemics. Now, this will take in all the disciplines almost that humanity has to offer, all of the knowledge and all of the wisdom, because few things affect the world as deeply as pandemics, except maybe something like world or nuclear war. So we hope to touch on all of these things for many reasons, which were already discussed, but also to honor the moment and to realize that when we come through this, the world can be a better place. I'm told by one of my colleagues that the word in Chinese for crisis consists of two symbols. The first symbol for crisis is danger. The second is opportunity, and we are faced with both now. So today we're going to enter into the discussion by talking about the basics, some of the primers of what will, as we move forward. And there's no better way to do this than with a discussion of epidemiology. So with that, I'm pleased to reintroduce Dr. Fleming-Davies. Professor?
I've entitled my talk, Epidemiology 101. So as Dr. Dominguez already said, today is all about getting you set up with the basic background that you'll need for the rest of the course. And I'm doing that in the context specifically of epidemiology. So my field is actually not epidemiology, but disease ecology. So disease ecology is the study of how infectious diseases spread in populations. And in disease ecology, we study both the pathogens, which are the microorganisms that cause disease, whether a bacteria, a virus, or a parasite. And we also study the host. So the host is the animal or plant that is infected by the disease. So disease ecology studies a whole range of organisms. So animals get diseases, plants get diseases, invertebrates get diseases. So we have coral bleaching is caused in part by bacterial pathogens. A lot of human diseases are included in disease ecology. So the Ebola epidemic recently, and now the current coronavirus epidemic. And so I wanted to just start out to clarify how these fields overlap and then which part of each of these fields we're going to be talking about today. So disease ecology and epidemiology both study infectious diseases in human populations. Disease ecology also studies infectious diseases in other species, so non-human animals and plants. And epidemiology also studies non-infectious disease, right? So it includes common causes of human mortality, such as cancer, heart disease, diabetes. So these are not caused by pathogens. They're not infectious. You can't catch diabetes from someone else. Most cancers are not infectious, a couple of exceptions. So today we're going to be focusing on this intersection in the context of the current pandemic, which is the idea of how infectious diseases spread in human populations, and what are the basic epidemiological or disease ecology terms that can help us understand what's going on. So my goal for you is that by the end of this really short talk, you'll be able to better interpret the statistics and the graphs that you see in the news, right? So what is an epidemic actually, a pandemic? How do these epidemics start and end? What are traits of the diseases, characteristics of these microorganisms that affect whether an epidemic occurs? We're going to look at a few epidemic curves, and then we're going to talk very briefly about herd immunity and how that works, since that's been in the news a lot as well. So let's start with our very, very basic vocabulary. So an epidemic is a disease outbreak. So the scientific definition is that you have an increase in the number of infected individuals. So epidemic, the term epidemic doesn't tell us anything about scale, right? So if you get sick and with a cold, say, and then your little brother gets sick and your mom gets sick too, and your dad, that's considered an epidemic, right? Because we started with one infected person in your household, which was you, and then it spread to 4 people total. A pandemic, on the other hand, doesn't have a clear, commonly agreed on scientific definition. It's more of a political term. So it is something that happens on a very large scale. Typically, it happens on a global scale. Some organizations will define it in terms of how many continents are affected. It's not necessarily agreed on though, right? So the key is that this is something that has really large implications for human health, or possibly for wildlife conservation, and it's happening on a large scale. So while all pandemics are epidemics, not all epidemics are pandemics. How do epidemics start? And importantly, now that we're in the middle of one, how do they end? So this is just a very simple visualization where we have a population where the entire population is what we call susceptible to this disease. No one has any pre-existing immunity. Everyone is open to infection by this disease. This is actually a really rare case in epidemiology because for most diseases, some people in the population will have had prior exposure to the disease, and so they'll have some amount of immunity. This is the case for our current pandemic, right? No one had any immunity because it was a brand new disease. So in the simulation, you'll see starting from this central dot, as these contacts are formed, our disease spreads and more people in the population are becoming infected. So note that it's not that the person in the middle is infecting everybody else. The person in the middle is infecting these people around them, who then infect others, who then infect others, and thus the disease spreads through our population. And so when we're thinking about what determines whether this will happen, right? Whether we will have a disease outbreak at all, it's amazingly simple. So there are just two traits, two characteristics of any disease that for the vast majority of the diseases will determine whether an outbreak is going to happen at all, and then how big that outbreak peak is going to be and how quickly it's going to go away. So you might have heard R0 mentioned in the news. So R0 is a way of sort of summarizing all these different factors that affect how diseases spread. And R0 gives us, on average, the number of new infections per infected individual. So if you get sick, how many people are you going to infect on average over the entire course of your sickness? So in our simplest model, this is just our transmission rate divided by our recovery rate. So our transmission rate is the number of new infections per person per day. So each day or unit of time that you're sick, how many people do you infect? And then the recovery rate is how quickly you get over the disease, right? So the two things that really matter here are how many people do you infect per day, and then how long are you sick, right? So if you're infecting 2 people per day, but you're only sick for 2 days, that's going to be a much smaller total than if you're infecting 2 people per day and you're sick for a week or 2 or 3 months. So when we look at these epidemic curves, we can predict pretty well whether an outbreak is going to happen or not, and how big of a peak it's going to be, just based on these two factors, these two traits of a disease. So on the right here, I have what one of these curves looks like. And usually this is from our traditional SIR model. So S stands for susceptible. So from the point of view of a disease ecologist, everyone who is not yet infected is a potential host for the disease, right? So we think of people not as healthy, but as susceptible. You might be able to get sick. Then infected is this red line, are numbers of infected individuals. So people are currently sick. And then recovered is blue. So as people get sick, they don't stay sick forever. They then recover, and then they join this, this blue line up here. So we look at what these different curves might look like for different cases of R0. We can see really different outcomes. So I'm just going to show the infected curve now, because that's what we typically see in the news. So R0 of 2, we get an outbreak, we get an epidemic, we have this small peak here. R0 of 7, we're getting an outbreak again, but it's much sharper of a peak. So it's happening faster, and it is a larger fraction of our population getting infected all at once. If our R0 is less than 1, we're not going to get an outbreak at all. It just dies off. Why? Well, because remember, our R0 is the number of new infections per infected person. So if you're infecting less than 1 person, right, on average, again, these are averages, it's not that actually that you're infecting half a person, then over time, fewer and fewer people are going to be infected. And that means that our R0 less than 1 means the epidemic's going to die out. So all public health measures are attempts to reduce this R0 to get it less than 1 so that the outbreak will go away. And most of them work by lowering this transmission term. So you might also have interventions that reduce the amount of time you're sick, like disease treatments, but most things all affect transmission. So things like wearing masks, the reason that mask wearing has become popular public health intervention is that based on the mode of transmission of this disease, wearing masks can reduce that transmission rate. So if you're sick, having a mask on reduces the chance of you spewing viral particles into the air for someone else to get sick from. It also reduces the chance of you taking in those viral particles if you are not sick yet. So this is how all of these measures work, right? They're all trying to reduce R0, which will slow down the spread of our disease. So the stay-at-home order, very kind of blunt force instrument for public health, right? If people are all in their homes, they cannot interact, they cannot contact each other, therefore there will not be transmission. So here is a real epidemic curve, right? So these are all model results. Here's the one that we're actually in. So this is the number of active cases in the US. So active cases means you're currently infected. So if we look at these previous peaks, right, they all go up and they go down. That's because you don't stay sick forever. So this is where we are right now in the US. So about 2.5 million people have been infected in total, but only about 1.5 million are sick right now. So we can see, right, if you hear people talking about the second wave, that's completely false. We're not even to the middle of the first wave yet. We haven't even reached that peak that then has to go back down to have that first wave. We have not had a first wave yet. So in case you're wondering, you're like, wait, I've seen the epidemic curve in the news. It didn't look like that. It looked more like this. This is not the epidemic curve. So you might have seen this in the news. This is being reported a lot, including from some very reputable news sources. The difference between this and the last one is that this is the number of new reported cases, not the number of currently active infections. So this is also important. It tells us how steeply that other curve is increasing, right? Whether it's increasing steeply or not, but it doesn't tell us who is currently infected. And the reason who is currently infected really matters is because remember, that's how our disease spreads. So with 1.5 million people currently infected, possibly outspreading the disease, and again, note this is just known cases, right? So conservative estimates say probably a factor of 10. So 10 times as many people are infected but have not been tested. So in order for the outbreak to die out, we need to decrease the number of people who are actively spreading the disease. So again, this is the one that's our epidemic curve. And so just for a comparison, because the US epidemic curve looks so weird, let's look at Germany's. So here on the right, this is our epidemic curve. Here on the left, this is our new cases. So you can see there's some correspondence, right? Where we have more new daily cases, we're increasing our active cases more steeply. So we have a steep slope on the right where we have lots of new cases. In Germany's case, they actually are through their first wave and potentially starting a second wave if you look at the late June cases here. So I just want to talk briefly about the different measures of epidemic severity. Why are we using this new reported cases curve so often instead of the active cases? So the best metric to know where we are in an epidemic and what's going on is the number of current infections. So this active infection curve, that blue line. But it depends on good testing, right? And one thing the US has really failed at is testing asymptomatic people. So our tests are very limited still, unfortunately, which means that they're often restricted to people who have symptoms. And in the case of COVID, there's so many asymptomatic cases that we're missing many of those. So number of new deaths is another thing we could look at. So I'm not gonna say the good thing about deaths because this is pretty terrible, right? But a feature of deaths is that they're harder to miss than infections, right? It's still possible to miss some. You might misattribute the cause of death, but if lots of people are dying in your population, you're going to notice. The problem is that there's a time lag that's up to a month. So you wouldn't expect the number of new deaths to rise until possibly a month after your number of new cases rise. And that can be a problem, right? It's pretty late to do anything about it. Hospitalization rate is similar, right? So it's easier to count. But it also lags, not as much as deaths, but at least 1 to 2 weeks. So in the absence of good testing data, what we can do is we can kind of combine several of these metrics to figure out what's going on. So the number of infections, right? The number of recorded infections from tests, the percent of tests that are coming up positive, and then our hospitalization or death rate. So if we look at these data for San Diego, this is from the San Diego County COVID dashboard. So here on the left, we have the total cumulative cases. So no, this is not active cases. This is cumulative, which means that we're not taking out the people who have gotten better. So this is just if you've ever had COVID since the beginning of March. And then new cases, which this is a kind of an unfortunate graph choice on the part of the county because it's really hard to read this part of the graph. But what we can see is if we look at our cumulative total cases, this slope gets steeper, which tells us that even though it's hard to see our numbers of new cases, they've actually started increasing. But if we look at the number of tests we've done, they're also increasing. So how do we know whether this increase in total cases is actually due to an increase in infections or if we're just catching more of them because we're testing more? Well, the key to figuring that out is to look at the percent of positive tests, right? So out of all the people who take a COVID test, what percent test positive? And so what we can see is that that rate is also sharply increasing again. So the combination of these tells us that there's very strong evidence for a true increase in COVID in San Diego County in about the last 2 to 3 weeks, right? Because we have this curve on the left is increasing and this is increasing as well. So last thing that I want to cover is a little bit about herd immunity. I'm not going to talk about vaccines because that's a whole other biological topic that I believe Dr. Holman, also from biology, is going to address in a few weeks. But I just want to talk about the basic process of herd immunity, which is to stop this from happening. So if we look at this graphic, now we've taken that blue background where everyone is susceptible and we've vaccinated some of our population. So this also works if people have immunity from prior exposure. All vaccines do is induce your normal, natural immune response by exposing you to a tiny or harmless bit of pathogen. So as we go from 0 to 95% of our population vaccinated, we're going to see what happens to the spread of the disease. So we can see that when we have 0% vaccinated, it's spreading very quickly. 25%, spreading more slowly, right? But the key thing is that above a certain percentage, it's not going to spread at all. And that's herd immunity. It's not just that it slows the spread. Even with some people immune, the spread will slow down. But it will also stop it completely if our percent immune is high enough. And the way that this works is really simple. It just reduces the chance that whoever you interact with can't get sick from you if you're sick, right? So if our initial infected person interacts with 5 people in one day, if none of them are immune, all 5 of those people could get sick, and then each of those 5 people could interact with another 5, and thus our disease spread. If, say, 3 of those people out of 5 are vaccinated, then our infected person only got 2 people sick, right? Our R0 has gone down. So all it does is reducing the chance that people contacted will get sick. So this is a typo, finish this sentence for me. So the more infectious our diseases with a higher R0, the more people must be immune or vaccinated in order to stop the spread. So the key here, though, is that this herd immunity protects the whole herd. So it doesn't just protect you directly with a vaccine, it also protects people who cannot be vaccinated for whatever reason. Perhaps they are immunocompromised. So childhood cancer, a lot of childhood leukemia patients cannot safely be vaccinated. Most people can, 99%, more than 99%, 99.999% of people can be. But the herd immunity protects those who can't as well. So this is why we're all hoping for a vaccine so much in the case of COVID, right? We can look at a similar case, right? So measles is an airborne disease, it has a very high R0, even higher than COVID. And we can see when the vaccine was introduced, we get this rapid drop off in cases due to this herd immunity phenomenon. We vaccinated enough people for measles in the US that it basically stopped the spread. All right, so that's all I have to say.
So welcome. I'm a physicist and I'm interested in pretty much everything in the world, but the thing that distinguishes the world is that everything changes. There's nothing that doesn't change over some period of time. In fact, you can't even define what time is except by change. Ticking of a clock, oscillations of a molecule or an atom. It's only by change that we measure time, but the conundrum is time is measured in change and change is measured in time. It's kind of a chicken and the egg problem here. But let's talk about how fast and how slow things change. This is about a 1 kilogram sample of the refractory metal molybdenum. It is very dense, it's unusual, and you could take this cylinder of molybdenum and sit it on a table for 100,000 years and it wouldn't change at all. It would just sit there. That's slow change. If you increase the rate of change by a factor of something like 1 trillion, that would correspond to something like the motion of a ball. That happens on the order of a second. Or if you take something like a $20 bill and tear it up, that takes about a second as well. Okay, so things on that time scale we're familiar with. But things can happen very fast as well. The molecular vibrations in your body and the transitions in chemicals and atoms in your body, molecules can occur on the order of trillions of seconds, 1 trillion times faster than that. So let's take a look just at a generic curve. If we take the quantity of something, we'll call it n, and watch how it changes in time, it can change at various rates. Sometimes it changes fast, sometimes it changes in the negative sense, sometimes it's not changing at all, but it's always changing. So if one looks at the rate of change of something, one can usually write an expression for it. Perhaps the most important expression is when the rate of change of some quantity n is proportional to n. How much you have of something determines how fast that something changes. If you have a radioactive element, how much you have of it tells you how many radioactive decays you have. If you have so many people and you have a certain R number associated with a spread of a disease, that tells you how fast the infection rate changes. But one of the most beautiful and important ones corresponds to this. When the rate of change, the change in dn over the change in time is some quantity plus or minus some constant times the quantity itself. When you have that, you're guaranteed to get what's called an exponential curve. So those exponential curves can increase. In other words, n can go up in time or it can go down in time. From what Dr. Fleming-Davies was talking about, if it's going up in time, that would correspond to an R greater than R naught, an R naught greater than 1, and going down in time would correspond to an R naught less than 1. So let's look at a few examples of growth and decay associated with the exponential. We'll look at bacterial growth, something called acoustic feedback, which you've probably experienced in your home, catenary curves, and investments. So let's start with bacterial growth. Let's say that we have a single bacterium. And that bacterium would be roughly anywhere from 1 to 10 microns. If we take one to be roughly about 1/2 micron, that's 5×10 to the minus 6 meters, that corresponds to a little bit smaller than a blood cell. And the mass of it can be shown to be roughly about 10 to the minus 13 kilograms. So to compare that to the mass of a dime, it's about 100 billionth the mass of a dime. It's a very, very tiny amount of mass. And let's say that the doubling time of bacteria is typical, of this bacterium is typical. Typical bacteria will divide and double anywhere from 12 minutes to 24 hours. Let's just say it's 10 minutes and be done with it. So every 10 minutes, the number of bacteria in a sample doubles. So, a question, after 24 hours, how big is the colony of bacteria if it's doubling every 10 minutes? So let me give you about 30 seconds or a minute to think about it, and then we'll work it out. So go to a piece of paper and say, If we double something every 10 minutes in one day, how big is that number? Okay, go to it, and we'll get to it, and we'll figure it out in just a minute. Okay, we can start by just kind of doubling numbers. Let's say we start with the number 2. We have 2, 4, 8, 16, 32, 64, 128, 256, 512, 1024, 2048, 4096, 8192, 16384, 32,768, 65,536, 131,072, 262,144, 524,288, 1,048,576. So after 20 doublings, we have about 1 million. But let's look at these numbers exactly. Down a little bit. We have the numbers doubling, 2, 4, 8, 16. And we have 24 times 6 doublings. Every hour there's 6 doublings. So in 24 hours, there's 144 doublings. So the number of bacteria we would have after 24 hours in this case would be 2 to the 144th power. Well, that doesn't sound so big, but let's put it into perspective. The rule of thumb is that roughly 2 to the 10th is 1,000, which we just did. So if we take 2 to the 144th right here, and re-express it as 2 to the 10th to the 14.4, which is the same thing, we can re-express that as 10 to the 3rd to the 14.4, which is 10 to the 43rd power and a little change. Let's just call it 10 to the 43. So after 24 hours, we have 10 to the 43 bacteria. This is an example of true exponential growth. Now, what is the mass of our colony after 24 hours? Well, if we look at the number of bacteria after 24 hours right here, and multiply by the mass of an individual bacterium, we get 10 to the 43 times 10 to the minus 13 kilograms, or 10 to the 30th kilograms. Well, let's compare that to the mass of the Earth and the mass of the Sun. The mass of the Earth is only 6 10 to the 24th kilograms, and the mass of the Sun is only 2 times 10 to the 30th. That means that if you took a single bacteria and you let it multiply, double every 10 minutes for 24 hours, it would be 160,000 times the mass of the Earth and half the mass of the Sun. So why doesn't this happen? Dr. Fleming-Davies, why doesn't this happen?
Something else must be stopping this from happening.
Exactly. The first thing that's missing here is that who's going to feed all these bacteria with something that the mass of the Sun? You couldn't do it. So first of all, it's going to run out of food. Secondly, bacteria are always living and dying. They're not all going to be there at the end of 24 hours. They may even eat each other. Who knows? But this is an unrealistic example if you take it out too far, which tells you something important. When it comes to physics, it's always a modeling of the universe. It's a modeling of nature, but every model eventually breaks down. And one of the keys to being a good physicist or a good scientist is to know when your model applies and when it doesn't. This model applies in the early stages of bacterial growth, but after a few hours, it probably isn't a very good predictor. And in fact, it certainly isn't after a full day. Okay, let's try another example. Okay, so to remind yourself again, we have exponential growth can either be positive or negative depending on the sign of the exponential. Next. So let's look at something that happens in everyday life. For this, we're going to talk about something called acoustic feedback. This is what happens when you bring a microphone too close to a speaker. So let's see how that works. Here's a speaker system. There's the speaker on the front, and there's an amplifier here. I'm going to turn this on. And if we look at the speaker and bring a microphone close toward it, at first you don't hear much, but as you bring the speaker closer to the microphone closer to the speaker, hearing a little bit of noise. And if you get too close, it kind of overwhelms things. This is acoustic feedback. You've all probably heard it. And the reason for it is this. The microphone over here picks up sound from wherever the sound may come from my voice or from the ambient conditions. The speaker puts out sound. So if the microphone picks up sound, sends it to the amplifier into the speaker, which sends out sound, which is picked up by the microphone, that goes back to the speaker and gets re-amplified. And pretty soon there's a feedback system where the amount of sound becomes proportional, the rate of change of sound becomes proportional to the amount of sound that you have, which is the exponential. And this is the growing exponential. Now, how could you fix this? Well, you can put something to damp it in between. And for this, I'm going to bring in one of the laboratory assistants, Connor Hotby, and we have a piece of styrofoam. So let's say that we bring the microphone close to the speaker to the point where it's about to run away. And now we stick a piece of styrofoam in between. It kills off the growth. And in fact, I can bring the microphone closer again to the speaker with no effect. But if I take away and put it back, it goes away, take it away, and it goes off, and it takes off and bring it up. This is like wearing a mask. If you wear a mask, then the virus cannot spread to the next person as easily, and you've damped out the transmission of the virus. You have reduced R naught. Take the mask away, and your virus begins to multiply quickly again, and your epidemic is off and running once again. Thank you. Now, one thing you also noticed is after the sound stopped being amplified, or just even listening to my voice, it goes away eventually, doesn't it? Sound does not hang around. What happens? Well, it goes through acoustic damping. The sound hits the walls, it hits your clothes, it bounces off curtains, whatever it hits, it's losing energy. And so the energy of sound eventually goes away. Imagine what your life would be like if you didn't have acoustic damping, if you were in a room with your friends and all their voices stayed around and didn't damp. It would just keep getting noisier and noisier and noisier. So damping is a good thing. It's nature's way of forgetting, for allowing new things to happen. As another example of an exponential, let's just take a look at something like a hanging rope, or just let's say a telephone line. You've all noticed that if you have a telephone line, it has a shape like this. This shape, right like this, is called a catenary. But a catenary is nothing more than a decaying exponential and an increasing exponential together. When you add the two together and average them, you get something called the hyperbolic cosine of x. And that is basically a sum of two exponentials. Exponentials are everywhere. If you read the handout for this week, which I wrote, at the end I wrote a number of questions, one of which was, if anybody can show me something in nature that does not somehow involve an exponential, I'll buy you lunch. And I really mean that. You would certainly teach me something if you could, because the exponential is found everywhere, not just in nature, but in human affairs. And I'm not sure this is the best graph there is, but this is a plot. Let me see if I can write it out again here. This is a curve for the amount of money that you'd have as a function of time if you make an initial investment. S $ sub naught is the amount of money you put in. K is your investment rate, your return, and T is time. And you'll find that in the long term, the amount of money you have increases exponentially in time if you have a positive investment constant. And it's a constant through time. So when you put money in the bank, you would like to put it in at something like 5 or 6% interest, and over time that money would grow. And so another question that I asked at the end of your handout was, How much money would you have if you took the money that you would have invested in your college education and put it into an investment instrument for 40 years until you retire? That might be something you might want to work out as well, which would help put a fine point on what is the value of a college education. Is it simply monetary, or is there something deeper to it? Now, to address questions economic and those of the liberal arts, the perfect person would be Professor Ma.
We tend to be a little bit geeky about our subject, and we think it's very interesting, and we think we see it everywhere, right? So you heard that from Dr. Sheehan, and you're going to hear that from me, that as I noted earlier, you're going to see economics everywhere. So I'm sort of the segue between the hard science and then the social science. I will also be showing you some modeling, but I'll leave the math for those of you who want to potentially major in econ. See this? So this is the epicurve that many of you, or probably all of you, have seen in the news, particularly during the early months in March or so, as we knew less about COVID-19 than we do now. So the epicurve, there was a lot said about flattening this curve, and the reason for the objective to flatten the curve is so that we decrease the demand for hospital beds. If there is a surge in hospitalization, then doctors would also, or other health professionals would have to make the decision between which individuals to save. So by having the containment policies that we have in many of the states in the US and even around the world, by forcing the social distance between households, then we were able to flatten the curve by decreasing the number of potential new cases, which led to fewer deaths. So you can see that the red line would be new cases without the containment policy. So there'd be expected a higher number of deaths, and then the blue line, which would be with the containment policy. So you saw that a lot in the news. On the flip side, we have what the economists look at, which would be the recession curves. So it should be first noted that even without any containment policies, economists expect that there would be a recession, potentially a relatively mild recession, because individuals who have the virus would not be able to go to work. If they are at home taking care of loved ones that have the virus, these individuals would also not be able to go to work. Others that are concerned about catching the virus would not go about in their daily activities, going to the movies, to the restaurants, as well as individuals that are concerned about the economy due to COVID-19 will potentially dial back their spending habits. So all of these, as well as businesses uncertain about the economy, may also decrease their investment. All of these activities would lead to a recession. With the containment policy, you can see that without any economic rescue package such as the CARES Act, economists expect that the death toll would be low, but the recession would be severe. In the US, as I noted, with having both the containment policies in many of the states as well as the CARES Act, the death toll was expected to be low, as well as there would be a recession, but it would be less persistent and less severe. So in this one graph, what I like about it is that it really connects the hard science that we heard from Dr. Fleming-Davies and Dr. Sheehan with the social science. And I'm going to focus a little bit more on the econ with the next couple of slides. So in economics, we have a modeling of the economy, which we call the circular flow. So in this circular flow, we have businesses. The businesses provide households with goods and services in what we call the product market. So when we think of goods and services, we often think about things such as cars or our smartphone. But if you really think about it, right, think of the time you wake up to the time you go to bed. You wake up and you may check your phone, so that's a good, right? You may use your data or your Wi-Fi. That would be a service. Then potentially you may listen to Spotify as you get ready, and that's another service. You brush your teeth with a toothbrush, toothpaste, your face wash, those are all goods and services. You put on your clothes, that's another good. Then you have your breakfast. Your breakfast may be a cup of coffee, maybe your avocado toast, and then some eggs, right? And then you go about in your regular day. At some point, you may binge watch some of your favorite shows on Netflix. That's a service. And then you may also join a meeting such as this one on Zoom. That's another service. So if you think about all the activities, you can see where I'm going, right? You have lunch, whether it be at a restaurant, that'd be a service, or you make a sandwich for yourself at home. Those are all the consumptions that we take on every single day from the time we wake up to the time we go to bed. Of course, the businesses are more than happy to provide us with these goods and services because we pay them a good amount of money for these goods and services. In order to produce these goods and services, the firms, as well as the household, we exchange in what is called the factors market. So the firms purchase our labor hours. They also purchase capital, whether that be human capital, financial or physical capital. They use natural resources as well as entrepreneurship in order to produce these goods and services. And in return for our labor hours, they provide us or pay us in wages. So the products markets would be the goods and services that we purchase in the factors market, would be the services that the businesses purchase from us. So this is a very simplified model of how the economy works. And now I'm going to make it a little bit more realistic by adding in the government. But before I do that, I want to share with you a quote by a Berkeley economist. He says that a modern economy is a complex web of interconnected parties, employees, firms, suppliers, consumers, banks, and financial intermediaries. Everyone is someone else's employee, customer, lender, etc. So we are all interconnected. So now I'm going to show you the exact same graph, but again, we're going to model the real world just a little bit more. And in the middle, we have the government. I've added in the financial sector, as well as other countries in this area we call the rest of the world, right? So if we start off with the disease, COVID-19, as well as the soft reopening of some businesses and then containment policies and others, that means that not everyone's back to work. So therefore, the linkage between businesses paying wages to households, that is broken, as some households have less income being earned. Others may not have any income at all from businesses or from working. And due to the decrease in earnings, there's going to be a break in the amount that households are able to spend. They're not going to be able to go about going back to the movies, to the bowling alleys, to the restaurants and bars like they used to. With less income, households may not be able to save as much as they used to. That will impact the financial sector. Other households will be taking money out of their bank account in order to pay for basic necessities. Less income means that the government will be collecting less taxes from households, which means that the government will have less to spend in terms of goods and services that they typically purchase from businesses. In addition to purchasing less from domestic firms, we also buy less from abroad. So whether that be not going on that European trip to Italy, or maybe holding on to your iPhone for yet another year with the phones produced in China, or potentially holding off on upgrading the new Audi that your family was thinking about, right? So that would impact the income that the other countries would receive, which in turn would then impact the goods and services they are able to purchase by firms that are producing these goods and services in the US. So this would include the trips that are canceled by foreign tourists. This will impact economies that are tourism-based. So think of Vegas, think of Disney World. With the cancellation of Comic-Con in San Diego, that will also impact businesses in San Diego, whether it be hotels, restaurants, SeaWorld, and other activities. as some of these businesses have less consumers due to individuals holding back on their consumptions, as well as others that are not able to purchase as much as they used to, some businesses will not be able to weather the storm and they will close. Other businesses will not have the cash flow in order to pay their suppliers as well as their workers. This will lead banks to have stricter guidelines in terms of making out loans, and that leads to a liquidity constraint, which then further exacerbates the problem in terms of the firms being able to pay their suppliers and as well as their workers. So the decrease in income received by these businesses will then also mean that the government will have less taxes, which then translates to a lower level of transfers that household will receive. So the big picture in all of this graph is to show you how a break in any of these supply and demand linkages will have a cascading chains of disruption in our economy. And the story that I want to sort of share with you overall is to show that you matter, we all matter, right? The decisions you make, whether it be in consumption or any of your daily activities, that will impact directly not only the individuals around you, such as your family and friends, but it will also impact individuals that you may not know indirectly. Additionally, those before us, the decisions that they made in terms of dealing with previous pandemics and other diseases helped to shape the world that we are in today. And then as we move forward, the decisions you make in terms of consumption, as well as wearing a mask, not wearing a mask, or how we even treat one another, will shape our society as a whole. So with that being said, I'm going to pass the baton over to Dr. Tirrell, who will talk about past pandemics.
And we're going to start off talking about just generally what has happened throughout a couple, really 2 points in history before the plagues, and noting that in both of those cases, there were 3 factors. There are many, many factors, but 3 factors that stand out: globalization, inequality, and the environment. And then we'll end by thinking about how those factors continue to play a role in COVID right now, and just generally in the risks that we face as a society. But I want to start off by reading, and I asked you to read this, The Second Coming by William Butler Yeats, who's an Irish poet. Writing this, I hope you had a chance to look at it, although there are parts of it that are quite dense. We're going to focus on the first stanza because the second one does require a lot more unpacking. But the first one, I think, can provide a lot of interesting thoughts for us, given that he wrote this during the Spanish influenza, which we might know actually originated in Kansas. So we should think about that when we're naming pandemics. It was during the end of World War I, and in the midst of the Irish War of Independence, and they had grievances going back hundreds of years around British oppression. So he was going through some stuff just as we are going through some stuff now, and maybe his thoughts can tell us some things that at least could help guide our inquiry. So I'm going to focus on a few lines here. The first one I think is really important: turning and turning in the widening gyre, the falcon cannot hear the falconer. Now, first, I think that's really important because there's a real disturbing thought here that something that we thought was under our control is no longer listening to us. And we can think of so many things, I'm sure, in modern society that we thought we had under control. Disease being one of them, perhaps, and the environment being another, our economy being yet a third one. These are things that we're always humbled. It's not that we should have thought this. We can just look back in recent history to know that these things weren't true, but there's a real hubris around this, that we are sort of the masters of our society, of the ecological, of the economic, of everything. Actually, we have a hubris around that. And for Yeats, the word gyre had a very specific meaning. He used it, and he had notes that went along with his poem. He used it to mean specifically the time where one age is ending and there's a new age that's beginning. And that you can think of that either pessimistically or hopefully, and I think that's true of this entire poem. If we realize that we're up against some difficult things right now, the pandemic being one, but many issues that we're up against, maybe it's a good thing that one age is ending and another is opening. This might be a chance for some opportunities to be more thoughtful and better about how we govern. You know, I said that political science was about governance. This is a chance for us to think about governance. The next bit I want to talk about is things fall apart, the center cannot hold. A famous line that's been used as a title for a really amazing book, but also I think is very relatable right now. For many of us, it feels like things are falling apart in a variety of ways, as Dr. Majas mentioned. Of course, concerns about health. Of course, concerns about the economy right now. I saw it in the chat, lots of questions about both. Can we trust testing? What's going to happen with the economy? Is there a way to thread the needle and make it safe and make sure that everyone can get back to work? So it does feel like a time full of risks. And this line, mere anarchy is loosed upon the world. And I want us to reflect on the question of whether there is a less pessimistic reading of the pandemic. And can we think about new ways to find order and justice? You know, maybe this is a chance for us to reassess how things have been going. And a lot of the problems are of our own making. And can we try to avoid, somebody asked, is there a way to avoid future pandemics? And there are certainly ways to decrease the risk. This line is haunting. The ceremony of innocence is drowned. And the verb drown is very harsh there. And you can sense that Yeats is feeling pessimistic, but I'm wondering if we can think of the end of innocence. And I think it's for all of you who were coming of age in the time of pandemic. You know, you spent your last year of high school. That's supposed to be this joyous, this year of transition, this year where the world is opening for you, and you're facing a world that is more closed than it has been in a long time. You've been denied some innocence in a sense, but can we think about that as perhaps a chance to awaken to the challenges we're facing? And this is a time in college when you can think about which challenges you want to take on, how you want to help us navigate around some of these challenges. And finally, and I think this is the most important for our times, the best lack all conviction, while the worst are full of passionate intensity. And just think about all the folks who have said they know exactly what's happening right now. They know exactly what to do. We know exactly how the virus is going to proceed. And I think the ones that you might want to listen to the most are the ones who are a little unsure, because we are in unsure times. That doesn't mean that they don't know things. It actually means that they know enough to know that we're up against something pretty challenging. So I think that line is important, that when you hear somebody who says, look, I know exactly what's best for you, and especially if they say, it's me or something that I'm interested in, I would be wary of that. So I think it is a time for humility. Sorry, let me make this to full screen here. So I mentioned these common characteristics, the first being the environment, and realize that we think about environmental problems as being mostly human caused, and we have those in spades right now, but there are, of course, natural ones and are natural ones that we still face: earthquakes, volcanic eruptions. There was natural climate change. Now, natural climate change within the human time period was about 0.5 degree Celsius. The fact that we use the Fahrenheit system in the US is really challenging, because most Americans can't really figure out what 0.5 degree Celsius means. But lucky for us, it's about 0.9 degrees Fahrenheit, which is about a degree. So we'll call it a degree. So in the past, we've seen plus or minus 1 degree, and it's done some, as we'll see in the next slide, some extreme things to the world. And now we're talking about trying to stay under 2 degrees Celsius. Let's not let it get to 3, because that would be almost 5.5 degrees Fahrenheit, which would be a pretty big change. So the natural change that humans have gone through, and has caused a lot of problems for them, has been much smaller than the man-made climate change that we're up against in the future, and that's already started to take a grip. Globalization, so not only because of disease vectors such as trade routes, colonization, and the globalized economy we have now, but also our food systems, where we're just growing and shipping things around the world in both intensive and extensive ways. And what that means is we're both taking up more and more land and cutting down forests largely to do that, but also we're using agrochemicals and other additives to grow more food, to have a bigger yield. But as we know, with the effects of well, pesticides on bees, for example, and you may or may not know about the runoff of fertilizers creating dead zones in oceans, that takes a toll as well. And then how can we not be aware of inequality, and yet so many people who are the lucky ones don't think about it too much. So vulnerability to disease due to poverty or environmental hazards, or inaccessibility of healthcare, or the financial impact. So when we talk about the economy being in trouble, realize that that just reinforces vulnerabilities that many poor folks already face. So the first case study we'll look at here is Rome, because it's one of the first really well documented pandemics. And now we know that the events of starting in 541 CE, or 541 years, after the birth of Christ, were the bubonic plague. We didn't know that for a while, but now we do. So it's different. It's not a virus. It was bacterial, but it had some similar effects, and it was related to natural events. So a few years before that, there were two big events, cooling events probably. We're not totally sure, but nearly sure that it was two different volcanic eruptions in 535 and 540, that the ash that was spewed into the atmosphere led to what many called a year without summer. And then there were multiple years without summer. The ash literally stopped some of the energy from the sun getting through, and it led to crop failures, famine, and because of poor nutrition, vulnerability to disease. These times are called little ice ages. That's a real misnomer because they're nothing like an actual ice age. But what it meant was that we did see that sort of 1 degree Fahrenheit, half degree Celsius, some give or take a little bit, dip. And during these times, it happened a few times in human history, recorded history, you did see famines, you did see nutrition go down, you did see lots of death in those times. And if I had more time, there's a course where I catalog a lot of this. Sounds really cheerful, right? But if you're into that, you look out for that course where we talk about how the natural climate change, even small natural variations, has really done a lot to hamper human society. So it's called Justinian's plague because Justinian was the emperor at the time, but he also contracted the plague. The Roman trade routes spread the plague efficiently for those times. I mean, here we're talking about a spread within months or weeks. At that, and those times we're talking about spread over years. You can see at the top of the map, the British Isles, you're talking about a century later. So this thing hung around because, of course, we didn't have the modern medicine to treat it, and it would just crop up. And so the numbers here are where it hit hard, but it stuck around. And we just actually had a new case of the plague in Mongolia, I think, over the weekend. So it's still around. But we're better at identifying and, of course, stopping it. But just like now, the urban poor were the ones who were largely in danger. And there was still a huge inequality aspect to it. Justinian, the emperor himself, contracted the plague, but survived because he had access to wealth and healthcare, was able to do the things that would give him a chance to survive. So now we're going to jump way ahead. Again, within these short times we have to jump around. We'll jump up to colonization in the Americas. And what most of us learned about disease during the colonial period is not complete. So if you've heard about this, you've probably heard that the European colonizers brought lots of diseases with them, sometimes accidentally, sometimes purposefully. You might have heard of smallpox blankets being handed out. All of that is true in some cases. But there's increasing evidence that mortality was more multifaceted than just not having natural immunity to the disease. You could see that folks who avoided contact with Europeans, direct contact, but still contracted the disease, were more likely to survive because the Europeans also, in their colonizing force, brought social chaos, environmental destruction. They cut down a lot of trees. Plagues of sheep. What's meant there is that the sheep that were brought in other livestock were responsible for devegetation and for then causing the local ecology to collapse and the food systems people depended on collapsed with them and with that nutrition, and they were more vulnerable to disease. The flip side of this that very few people talk about, and really it was only in the last 15 years, I think, that there's been a discussion about this, was that European colonizers also selected settlement types based on climate and disease vulnerability. So you might notice that settler colonies are in temperate places, and plantation or extraction colonies are in tropical places. And that's largely now thought to be because Europeans wanted to avoid tropical diseases. And in doing so, they made settler colonies like the US and Canada and New Zealand and Australia, where they pushed out, killed, committed genocide, and indeed spread disease to native peoples. They made those into new little European societies. And the upshot of that many, many years later, hundreds of years later, is those societies were built to be good for the people. They have rule of law, inclusive economies, and nice infrastructure. They're some of the richest societies in the world today. Plantation societies, which used slave labor, had an economy that served sort of the upper caste of elite people who were overseeing the plantations and who were the slaveholders. And that infrastructure was all for the elite. And we see this even in shades in the US, where the American South was built on slavery, and it, in a relative sense, was not as inclusive as the Northeast. Think about the New England Town Hall and early public school systems in the Northeast versus tutors for the wealthiest slave-owning plantation holders. And then extraction colonies, where there was really no European, very few Europeans moved there, but rather they had a very authoritarian society that was just there to get whatever they came for, whether it's diamonds or rubber. They used extreme violence and force, brought a lot of death, and left, and almost no infrastructure, and left behind a system that was very authoritarian. So when you had decolonization of these various places, the settler colonies, as I said, turned out to be wealthy and turned out to have good institutions, political institutions. Plantation societies were somewhat mixed, but were very, very elitist. And extraction-based colonies turned into places where despotism could thrive, because the British and the French and the Dutch and the Spanish and the Portuguese left behind systems that would be very inviting to somebody who wanted to be a despot. They basically were authoritarians who left behind an authoritarian system for somebody to take up. So I think it's important to note that disease kind of cut both ways, both terrible ways, both decimated native societies and also led to really unfair, unequal outcomes for developing, what we now call developing countries, almost all of which were at some point colonies. So the lessons, since this is a very short run through, the lessons that we can hopefully take from all this and think about our current pandemic and what can we do with it. Maybe we can try to address some of the challenges related to the environment, globalization, and inequality by learning some things from the past, but also from our current pandemic. And I want to introduce one term here, the Overton window, which is when certain policies or certain ideas go from being, and you can see the scale on the right here, unthinkable, can't even talk about it, to radical, to acceptable, but we're not quite there yet, to sensible, we ought to do that, to popular, let's do it for sure, to policy. And I'm hopeful that some of the challenges we're up against now, and especially this moment where it feels like things are falling apart, will allow us to move on the Overton window for some things. We may be already seeing this movement with the Black Lives Matter cause, and I'm going to leave that to Dr. Miller to address more in her talk, but note that these conversations are changing quite a bit. Awareness of how the global system exploits poor citizens and developing countries. And we are asking questions, society by society, do we allow survival of the richest, or do we offer support to the vulnerable? And some societies are doing it one way and others are doing it the other. We might be focusing more on how we relate to food production. And if you grew up knowing what a factory farm was, you know that because society's starting to take notice. That was not a common term when I was your age. We didn't talk about this. If you've heard of deforestation stemming from agriculture, or pollution coming from the intensification use of agrochemicals, you may or may not have heard much about that, but if you have, it's because society is starting to really think about this and talk about this. There's a renewed interest in local production, in thinking about the life cycle of products, not throwing things away, trying to reuse things, and in simplified living. That was already happening, but maybe have been sped up by the pandemic and by being forced to think more in a more sometimes thrifty or in a more cautious way. And maybe beginning to notice that growth-based economies economics have put us in a bit of a vulnerable state with ecological and social decay. That is this constant hunger to consume more and more rather than just trying to have a good life where we're satisfied. It's the root of many problems that we face. And finally, I can't help but note that there are some connections potentially between the pandemic and climate change, not only because climate change will lead to future pandemics. If it's out of control, it will increase the potential for vectors. Some insects that can pass disease will be moving to new climates, or what used to be a climate zone that was uninviting will now invite new kinds of insects. Types of mosquitoes that can pass malaria, for example, might come well into the southern US. But also because climate change exacerbates many of the vulnerabilities that will cause a pandemic to run wild. So note that comparatively small climate changes in the past that were natural have had large impacts. So if we allow a very big climate change that's done by humans, we could have some very big impacts. But note that we're also talking about the urgency of the issue. So if you've heard of Greta Thunberg and the school strikes or Extinction Rebellion, that's because they're starting to pick up currency in our society. We might be rethinking what is necessary when we're faced with crises. Do we need all of these things? Do we need to travel around the world to conferences when we have the technology to avoid all of that extra travel? Maybe we'll be more cautious about how we use travel, more cautious about how we produce goods. We're not there yet. We might be more like the radical to acceptable scale. I'm not suggesting we're on the threshold, but for some people, we're close to sensible, and for others, they're ready for policy right now. And finally, the vulnerabilities that are caused and exacerbated by climate disasters are something that we'll have to reckon with. Here in California, we've had terrible wildfire seasons, in other places, terrible flooding, in still other places, drought and famine. And so these are things that when we think about vulnerability from the pandemic, hopefully we can extend some of those ideas to thinking about climate change and other environmental hazards. And I think that's what I have for you today.
Great, thank you, Dr. Tirrell. I'm very glad to build on a lot of what you shared here, especially these themes and concepts of inequality, inaccessibility. And what I will be doing is contextualizing the COVID-19 pandemic, especially as it affects African Americans, and thinking about much of what Dr. Tirrell has shared, which is this concept of historical lessons and lessons from haunting disparities. So when we look at the various headlines that have emerged amid COVID, many of them have looked like this. So I'm flashing some of them across your screen now. And they all share, of course, so much in common, and that is the finding that COVID-19 disproportionately dwells in Black neighborhoods, communities, and homes. And although only 13% of the population, African Americans represent 30% of COVID-19 cases, according to the Centers for Disease Control and Prevention. Disproportionate meaning because they are such a small portion of the population, there is no way they should be 30% of these cases. That's what we call imbalance. That is a clear disproportion. And you see here these headlines, which I definitely encourage you to explore, but you also see here graphs as well provided by various news networks and reputable sources. Some of them even get into specific localities, such as in the bottom right screen, and talk about how, again, in places like Illinois, Louisiana, and Michigan, what percentage they are of the population and to what extent they are affected by COVID. And we have to ask ourselves why. Why is this occurring? Well, history definitely tells us or offers us a window into the why, because history is cyclical. The past does not stay in the past, especially when it comes to Black American history. Experiences, practices, customs are reproduced. They never disappear. They never go away. and particularly if they lie at the foundation of the country, it is undoubtedly clear that history tends to repeat itself. So I want to go through some previous pandemics or epidemics and their impact on African Americans in order for us to be able to investigate and think about, but what might be causing their varied experience now. A prime example is yellow fever, the 1793 yellow fever epidemic in Philadelphia. Yellow fever is a tropical viral disease carried by mosquitoes, or a particular mosquito, and it causes jaundice and kidney failure and beyond. And it first appears in the United States in the 1690s, but it does occur again, or another outbreak comes about in the 1790s in Philadelphia. And as displayed here, within weeks, we have 100 people dying every day. And by the close of it, 10% of the city's population are fatally compromised. And physicians did not know at this time what the exact root cause of the pandemic was, or of this epidemic was, that it was actually mosquito, that if you did not suffer from this, it could be due to an acquired immunity. But what physicians did conclude was that Black people were immune to the disease. They found that while white settlers, especially newcomers coming into the East Coast, were vulnerable, they determined that African Americans didn't suffer from yellow fever. And they came to this conclusion because they compared and contrasted the bodies of Africans, enslaved Africans, who recently arrived to the nation's ports. Physicians were actually located at slave trading ports, and they would go onto the ships and inspect the Black cargo enslaved Africans. And they would compare and contrast how they responded to different health events in comparison to their white counterparts. And they concluded that there is something different about Black folk biologically that prevents them from suffering from this disease. And an example was published, or this conclusion was published by a prominent doctor, Dr. John Lining, in 1748, as early as 1748, when he wrote about the yellow fever, and drew the conclusion that Negroes are not liable to this fever, as his quote says, that they may be subject to it, but they actually never contract this fever. And again, years later, when it does arrive to Philadelphia, we have Dr. Benjamin Rush, who was a prominent Philadelphia doctor, take these findings, consider these findings, and use these to determine how to best grapple with the yellow fever in the city of Philadelphia. And he ultimately decides that these findings are accurate, that they're sound, and that the solution to target the yellow fever is to perhaps reach out to the Black community in Philadelphia and ask for their help. If they're immune, Black nurses, Black doctors, or Black volunteers can help white residents suffering from this disease. And he is an abolitionist. Dr. Benjamin Rush is anti-slavery, so he does have close ties to the Black community and reaches out to them, writes a letter in particular to Reverend Richard Allen, who is a prominent member of the Free Black community, founder of the Free African Society, the African Methodist Episcopal Church, the largest African American denomination, which is still in existence today. To be clear, by this time, there are almost 50,000 free African Americans in the United States as a result of the Revolutionary War. So this is the first sizable group of free Black Americans. But this is also the first group of Black Americans to deal with or find that freedom doesn't mean freedom, that there are actually laws and policies that the cities that they move to put in place that make it clear that although legally you're free, maybe they were freed by their slaveholders, you do not have the right to vote. There are certain places where you cannot live and beyond. So we also see at this point in history the architecture or the design of policies that intend to limit freedom, even though they legally have access to it. So they are self-sufficient. They build their own communities, their own churches, their own mutual aid societies. Richard Allen is known as one of the founding fathers of Black America because of the work that he did in this area. So Dr. Benjamin Rush reaches out to him and they agree to help. They believe that what they're being told, that they are immune to this disease, and they bury bodies. Black women nurses take care of white families. They often do so without pay. But it turns out that they are not immune after all. Hundreds of African Americans perish. And Dr. Benjamin Rush himself begins to notice this and says, wait a minute, I made a mistake. They are not immune. They, in fact, can contract this disease. And the consequence, again, of this concept of Black immunity, which one of your readings addresses, lends to the loss of life, the loss of many lives. And on top of that, while we have the loss of Black life, we also have the continuation of disparaging ideologies about African Americans. So this is a document written by Richard Allen and Absalom Jones, another founder of the Free African Society, in response to a publication by someone by the name of Matthew Carey, who accuses African Americans of looting, of stealing, of plundering the houses of the sick, of going in and not quite helping, but actually stealing things, taking things, maybe overcharging them for their services. And Richard Allen and Absalom Jones respond to this with their own publication. And I just include excerpts from that here, where they say that some of these lines I highlight or zone in on, where they say that, let's say that there are Black people guilty of plundering, and we acknowledge that. Let's say we acknowledge that. But we know as many whites who are guilty of it. But this is looked over while the Blacks are held up to be criticized. Is it a greater crime for a Black to pilfer than for a white to privateer? And they also describe excerpts of Black men poor, Black men and women who were poor, who would go in and help white families, but only to not be helped when they became sick. So they kind of recount their noble efforts, really reverse and tear apart the arguments of Matthew Carey. And they also assert that, again, they were not paid for many of their services, and that when they were paid, they definitely were not sufficient. And their expenses, the amount of money that they put out, definitely overrode what they received. So again, in spite of their help or their efforts, we still have the cyclical nature of disparaging ideologies. And actually the myth of Black immunity does not go away despite this finding. It only continues. I also want to talk about the smallpox epidemic of the 1860s, and which occurs again in the midst of the Civil War. The Civil War, I just provide some key information or reminders of what this moment looks like for African Americans. The enslaved determined that the Civil War would be a war for their freedom, because it was not a war for their freedom at its start, but African Americans made it so. They determined that they would run from their plantations to Union strongholds, overwhelm Union camps. Over 600,000 would flee. They would force the hand of the government and the military to pass confiscation acts, which asserted that after African Americans leave Confederate plantations, that they did not have to be returned, because again, they were legally property. And then eventually, Abraham Lincoln passes the Emancipation Proclamation, which is the last of these confiscation acts, which says that not only do they not need to be returned, but that they are free. Those in the rebel states, not all African Americans, like those in the middle colonies, just African Americans in the South would be free. So that's important to specify as well. But what does it mean to be free when you don't have shelter, clean clothing, food, basic necessities, and access to medical care amid a time of warfare and infectious diseases such as smallpox? So they would be disproportionately impacted by this disease. And also they would have, of course, lack of access to the resources they would need in order to heal. So we often think of the Emancipation Proclamation and the days after as a time of jubilee, as triumphant, but African Americans suffered significantly. Union camps were overcrowded, unsanitary, full. Thousands of African Americans were turned away and left to fend for themselves. They were not allowed to go into hospitals or receive medical attention in those capacities because they were newly freed Black folk. They were exposed to the elements in more ways than one. The days, again, were long and hard. And there are several or hundreds of thousands of fatalities on the part of African Americans. So imagine getting to freedom, but not being able to survive to see it, not being able to survive to experience it. So freedom was uneven, freedom was not swift, and it was not easy. I also want to, moving forward, and I know I'm moving quite swiftly here because I want to be mindful of time, and if there are questions that arise, I will definitely check them out in the chat so that we can answer those in discussion section as well. I just have images here of contraband, what African Americans were called when they fled plantations and would go into or near Union lines. Even again, the nature of their clothing demonstrates the extent to which they lacked access to the environments that would be conducive to preventing them from contracting something like smallpox. The third epidemic that I want to talk about is HIV/AIDS, which is more recent. It begins in the 1980s, 1990s, and is actually still present today. So I do want to be sure to highlight that. Center for the Disease, for Disease Prevention and Control do highlight again that this syndrome appears in the 1980s. And disproportionately, almost immediately, it's clear that African Americans are disproportionately impacted by this autoimmune disease, which begins as a virus and then turns into, which begins as HIV and then turns or evolves into AIDS. So I'm going to provide some statistics here that allow us to take a look at this disproportionate impact. Between June 1981 and August 1986, 25% of African American, 25% of the cases are among African Americans, although they are at that time 12% of the population. Okay, with children, 58% of the cases are among African Americans. When we move farther into the 1980s, Black women are more than 13 times higher to contract HIV/AIDS than their white and Hispanic counterparts. And then when we think about HIV in the 1990s, it becomes a leading cause of death for African American men, as I list here. And the second leading cause of death for African American women in the same age range, between 25 to 44. And I want to be clear that what we find is that this is not a result of personal choices or decisions, that African Americans are, this disease is contracted through sexual activity or through needles. It can be contracted through the blood, and it can be assumed by many that this must mean that they're doing things that are more harmful than any other group, and that's not the case. The activities among these populations were quite similar. What the root cause is we can think about structures, and there's one in particular that I want to talk about or highlight, and that is that the HIV/AIDS epidemic coincides with the war on drugs by the Ronald Reagan administration, which entailed the disproportionate policing and surveillance of African American communities on the part of law enforcement. This is a point in time where African Americans begin to fill prisons. Prisons, if you all are familiar with the type of environment that exists in prisons, they are unsanitary, they are unsafe. A great deal of activities occur in prisons that can yield to HIV/AIDS, and they often don't receive the medical support and services they need. So imagine 12% of the population. Into the 80s and 90s, they're becoming Black men alone, nearly 44% of the prison population. What happens when they encounter this carceral state? To what extent does their disproportionate exposure to this system also contribute to HIV/AIDS epidemic? Scholars also find that, again, Black communities, where Black folk live, where they're expected to live, or communities and spaces that they're pushed into due to long-running practices of housing segregation that begin in Richard Allen's time and continue into the 1980s and 1990s, do not have access to the medical support services and social services that they need in order to, again, prevent the contraction of this illness. So that is also a key cause of this epidemic. I want to, again, think about what these lessons tell us moving forward, what these lessons tell us about COVID and its impact on African Americans now. We've looked at a few pandemics, and there's things and practices that they similarly share. The disproportionate rate at which African Americans suffer from, as well as die from, are not due to personal choices, communal pathologies, the foods that they're eating. That's been a thing that's been discussed, or the ways in which they act or perform in public spaces. It's not biological, it's not inherent. What past in pandemics and epidemics tell us is that racial inequalities made possible by what scholars refer to as structural racism, they also call it institutional racism, the normalized and legitimized range of policies, practices, and attitudes that routinely produce cumulative and chronic adverse outcomes for people of color, especially Black people. That's a quote or definition by a scholar, Tricia Rose, that I think is a useful one. But that's something that each of those pandemics of the past share, but also pandemics of the pandemic of the present. When we consider housing, employment, school systems, and environmental policies that all work together to make African Americans vulnerable to this pandemic, I want to acknowledge that the vast majority of African Americans work in front-facing service, essential work positions. So we have forms of economic, employment discrimination, educational discrimination that determines the types of roles and jobs that they are able to access. We also have the housing discrimination, the likelihood of African Americans to live in multi-unit housing at present. They also were likely to live in multi-unit housing in 1793 Philadelphia. We also want to acknowledge that, again, that class, while race and ethnicity is a prominent factor here, we tend to also think that class is the main contributing source of these issues. And I want to be clear that class is only one vessel through which African American lives are shaped in society, because, to be clear, middle class African Americans, those who do access educational degrees and forms of income, are also disproportionately affected by COVID and beyond. I also want to think about ideologies. That myth of immunity is also at play here. And I want to refer to findings that have been collected in recent decades that emphasize and show that once African Americans access healthcare, so let's assume that they have access to healthcare. Right now, I'm not talking about their inability to access healthcare. I want to look at what happens when they enter into hospital rooms and offices. There is that myth of immunity that African Americans do not experience pain or suffering as much as their counterparts. And here I featured quotes from a great study called Unequal Treatment by the Institute of Medicine that highlights how doctors treat or perceive African American patients. They're less likely to receive pain medicine. Their pain is less likely to be taken seriously. And we have to ask ourselves, this myth of immunity, it has to be operating amid COVID if it was operating just before COVID. I mean, when ventilators are down, when ventilators are low, and a Black patient is in need, and there are others in the room who are not Black, who gets access to those finite resources? I want to highlight that cases are still coming out. Of course, this process, this pandemic is still ongoing, but we already have a myriad of testimonies and stories from African-American families who tell of stories and cases in which their loved ones were turned away when they were in need. They were told to go home and sleep it off. And I highlight here the story of Deborah Gatewood of Michigan, and this is just one of many stories. And with that, I'm going to conclude fast, quick, and in a hurry. But I do hope that the information that I provided and the terms I provided proved to be helpful and informative.
Thank you, everyone, so very much for all of these fascinating lectures. There's so many great questions. What we're going to do is we're going to start with Dr. Fleming-Davies because she has a few questions that she wanted to be sure and clarify.
Some of these into 4 things I thought were really important. I'm going to try to address the first 2 quickly, just because I want to make sure you guys had so many good questions, and this is not even close to all the ones from my section, let alone the whole course. But I wanted to first address vaccines, right? Are we going to be able to develop a successful vaccine? Isn't this vaccine being so slow, right? Can we even get immunity? Can't you get COVID twice, right? Don't antibodies go away? Are there multiple strains like there are with flu, right? So really important questions. So with an emerging disease, we're learning as we go, right? And we're learning we're in the middle of a public health crisis. So our best scientific guess in March is going to be updated, right? So you might have read one thing in March and then something else in May. That's just how the process of science works. It's not, no one's lying to you about that, right? So I'm going to start with, can't you get COVID twice? So as far as we know, most people over the short amount of time that COVID has existed, right, have immunity to a second exposure. Antibodies do go away, but antibodies are not the only immune response, right? So right now you don't likely have antibodies to measles in your blood, even though you had the MMR vaccine most likely. That doesn't mean you're not immune to measles, right? Your body will ramp up production of these antibodies based on its memory cells when you're exposed. So the reason that we're testing people for antibodies, the main reason, 1 is to get an idea of the prevalence in the population, right? And 2 is to use those antibodies as a treatment for really acutely ill people. And so that's why whether you have current antibodies right now matters for those things. So COVID has evolved a little bit since it was first introduced, but there's it seems to be pretty slow. So not a lot of genetic changes accumulating. This is good news for a vaccine, right? So you might have noticed, why do we need a new flu vaccine every year? And also the flu vaccine is sometimes pretty bad, right? It doesn't actually provide 100% protection. So why is that the case? And is it likely to be true for COVID? So the reason the flu vaccine is pretty bad some years has nothing to do with how good we are at making vaccines against flu and everything to do with how long it takes. So the flu evolves very quickly over time. And it evolves in the parts of the virus that our immune system recognizes, right? It's like this coevolution cat and mouse game. So that means that last year's flu strain is different from this year's flu strain, but it takes a whole year to develop enough to create, not even develop, to make enough vaccines to distribute globally. So what the problem is that the vaccine for this year's flu, we have to guess a year ahead of time what the strain is going to be next year. And then spend the whole year making it. It's often made in eggs still, and sometimes it'll just have genetic drift in the eggs, right? So that's the reason the flu vaccines can be not 100% effective from year to year. If we could make the vaccine really quickly, we could have really good flu vaccines, but we have to guess so far ahead of time how to make it that by the time the season comes around, some years we guess right and it's close to 100% effective. Other years we don't, and it's only maybe 30 or 50% effective. Note that even an ineffective vaccine still is going to help a lot in terms of slowing population spread. So it might not protect you in every case, but it will still work to slow the spread of disease. So So the middle question, right? Can't you get COVID? So first of all, to answer the first one really clearly, so far we have every evidence that it will be possible to develop a successful vaccine against COVID. It's just vaccine development is very slow. Couldn't we have done something to make it faster? Yeah, we could have actually. A couple of organizations, including in the US, had proposed after SARS to spend some time in development of coronavirus vaccines, right? SARS is another coronavirus. It didn't get funded, right? Everyone's like, SARS is over, why are we worrying about this? If we'd funded that SARS vaccine, we would have been able to get a COVID vaccine much faster, but we didn't. And so here we are. So the can't you give COVID twice question gets me to test accuracy. So all tests have false positive and false negatives. We call this sensitivity and specificity in the medical language. Does this mean we can still trust data about test count, like case counts that are coming from tests? So the answer is that we have to be very careful about interpreting test results on an individual basis, but on a population level, we can still get a really good idea of what's going on, even though our tests are never going to be 100% accurate.
We're delighted to have you all here. We're delighted to have the faculty. It was such an amazing discussion today and very thought-provoking.